are beginning to sign in, I'm going to start us off by just going over the CME and CE credit information. We'll also send this to you via handout after the meeting as well. The first step is to text the CE code 8337 to the number on the screen by 1 p.m. on April 26th. That said, if you miss this deadline and don't do it, the evaluation will still show up on your portal. It will just take a little bit longer until Beaumont's able to add the attendance from the meeting. So do not worry if you don't miss this step, or if you miss this step. And then second, we ask you to complete the required evaluation by May 11th in order to earn credit. For just financial disclosures for the meeting, Dr. Lauren Oshman, who is of course co-director, has stocks in publicly traded companies listed here. And then we are able to provide medicine CME, nursing CE, pharmacy CE, and dietetic CPEU 1 hour each for attendance at this meeting. I'll stop sharing now, and while Dr. Schmidt is pulling up his slides, I'll give a brief introduction, and then we'll introduce our second speaker, Dr. Ang, before her portion of the presentation. But we're very lucky today to have Dr. Brian Schmidt here, who is an associate professor of internal medicine in the Division of Metabolism, Endocrinology, and Diabetes at the University of Michigan Medical School. He completed his undergraduate studies at the University of Michigan and then proceeded to Rosalind Franklin University of Medicine and Science and graduated summa cum laude as a doctor of podiatric. Is that how you podiatric? Sorry, Dr. Schmidt, I'm probably saying that wrong. Please correct me.
No, you're okay. You're okay.
Okay, medicine. He has published numerous peer-reviewed manuscripts, book chapters, and is a leading expert in diabetic foot. Dr. Schmidt has applied his clinical interest to translational research to better understand and promote diabetic foot ulcer healing and limb salvage through science. He's actively supported in his research by the NIH and the National Institute of Diabetes and Digestive and Kidney Diseases, and is an active member in multiple medical societies and holds leadership roles. Thank you so much for being here today, and we're very excited to hear from you.
Well, thanks for that warm introduction. I'll just turn on my screen share here, and we're going to do a small adventure into diabetic foot. And high level, I'm going to give some examples today about just how exactly you should care for people when they present to you with diabetes and for people who have feet, very simply. So I'll give you some strategies. And of course, this is all I do. I'm pretty passionate about it. So, and I'm partnering with you. I'm available to you via email if there's additional questions at the end, but let's start. So first, I have no conflicts of interest to declare related to this. I think upon completion, we're going to really be able to describe diabetic foot risk categories and use them to guide treatment plan for these patients on the long-term aspect, because once they have diabetes, they always are going to need foot care and foot evaluations. So we'll set up a paradigm to do that. But first, let's go over the statistics, right? Why should we care about diabetic foot? These are old statistics now. I'll provide some updates, but 2017, there were about 425 million people with diabetes worldwide. And the lifetime risk, sadly, is about 1/3 of all people with diabetes will develop a foot ulcer during some point of their life after the diagnosis of diabetes. More than half, or more than, I think, half of diabetic foot ulcers, once you get them, become infected, and 20% of these result in an amputation. We know that the biggest predictor of when someone's going to get an amputation is if they have a diabetic foot ulcer. So our strategies the purpose of this is really to prevent and identify people who are at risk of or at risk of developing a foot ulcer because of some of concerns with diabetic foot. Sadly, we know that when people have an amputation, they're at risk of losing their other leg. And sadly, they often die quickly after the non-traumatic lower extremity amputation. But further, 5-year mortality, it's said to be up to 68%. Now, do they die from the diabetic foot ulcer or from the amputation? No, but it's a sequela of their overall comorbid status. This is representative of how sick they are, and so when they have that amputation, it certainly starts the clock on the end of their life, and we wanna do everything we can to extend their life and prevent these complications. Other things you should care about is that this is really costly. I mean, if we look at the context of diabetes care worldwide, it's close to the GDP of some small countries. But specifically for lower extremity wound care, just putting on those dressings and having the patient have a debridement, some of those things that I do on a regular basis, that costs the US economy anywhere from 20 billion upwards to new estimates of about 35 billion annually. This is very costly. In fact, it's about as costly as all of cancer care costs in the United States. So diabetic foot, similar to cancer, similar not only in outcomes, but also similar in
Paying for this.
cost to these patients. So, what can we do, right? Where should we start? Diabetic foot is a big thing. We all have experienced patients who have suffered probably diabetic foot infections requiring prolonged hospitalizations. And I think really the pertinent steps, and we're just going to keep it simple today, is understand the diabetic foot risk categories, how we look at that from a specialist perspective, and then I'll teach you a very simple but a very well-known and the most commonly used diabetic foot ulcer infection classification. We'll show you some different examples of the same ulcer so that you can get an idea of how these ulcers can morph and change over time. And then we'll relate it back to what we can do to prevent and stop these events from occurring. And one of the simple things is getting patients diabetic shoes and inserts. And we'll talk about some of the language that's required for it. But let's begin with understanding diabetic foot risk categories. And there's four, no concerns. We call it low risk, people who have normal plantar sensation, all the way up to people who have already experienced an amputation, who have neuropathy or have poor blood flow. And this really hasn't changed in 20 years. The American Diabetes Association, I think back in 2006, really started to publish what to do for each of these risk categories. And we haven't really updated it to be anything different in the last 20 years. So, good for us is that it's a great place to start for when you see a person with diabetes, what do you do with their feet? And the first thing I would always ask you to do when you have a patient with diabetes is have them take off their shoes and socks. It's just a quick look, put eyes on it, make a note if everything's normal appearing, that there's no ulcers or, wounds or drainage. Even if they smell, please make note of that because those are just indicators that, hey, I'm looking at the feet. There was no abnormal appearance, and that's okay. We have at least a baseline visit for them, and that's really where we want to start is this physical exam. And physical exam for people with diabetes is required by or recommended by the American Diabetes Association to be done at least annually. Doesn't matter if they're type 1 or type 2. People for type 1, it's recommended that they have an annual foot exam first and, initially one time a year. And if things are normal, then you can go to several years in between. But for type 2, we do want them to receive these annual inspections, if not more, and we'll kind of incorporate that with the other higher risk categories. So this includes general inspection, dermatologic, making sure there's no cracks or fissures or wounds or drainage from that area. How do their muscles work? Take them through range of motion, dorsiflexion, plantar flexion, inversion, eversion of the feet, just to make sure that their strengths are normal. We want to do a neurological assessment. This can include light touch sensation testing with either a pinprick, vibratory, or tuning fork, and we'll talk. I'm sure Dr. Eng will talk about that next, so I won't steal her thunder. But also palpate those pulses. Remember, they have the dorsalis pedis on the top of the foot, and on the back of the foot, towards the medial malleolus, they have the posterior tibialis. Both pulses should be palpable and symmetric bilaterally. If not, that should elevate your concern that this could be a complication of diabetes. From there, after you do this, there are multiple publications that say you should be able to do this in about 2 to 3 minutes. So I don't think it takes too much time, and you're going to do a great service for your patient. So After you do this and you say, oh, there's no real concerns, most of your patients are going to have very low concerns. But it's just patient education about appropriate footwear, not going barefoot, not wearing sandals, and inspecting their feet. Also encouraging them to follow up with you as the diabetologist or endocrinologist, probably annually, or primary care doc. At least annually, you should look at their feet. Am I asking you to look at their feet every visit? Yes, because I'm a podiatrist, but no, because it's not required if they have a normal exam. But keep that in mind. Take off those socks and just take a quick peek. This is opposed to if you do testing and they start to have loss of protective sensation via that Sims-Weinstein monofilament testing or reduced vibratory sensation. You're going to want to consider accommodative foot gear or shoe gear. We'll talk about diabetic shoes at the end, as I mentioned. And then at this point, I would refer, even if they have no severe complications or wounds or anything, at this point, I would say get them to a foot and ankle specialist, get them to somebody who is going to provide more specialized monitoring of them because you've identified that they have loss of protective sensation, and that's one of the greatest risks for developing a foot ulcer. So when should they see you? When you do your regular diabetes care. If they're coming in to have their medications adjusted, take a look at their feet as well, in addition to that referral to a foot and ankle specialist or a podiatrist like myself. Other things we want to keep in mind is that if they are higher risk, again, they start to show calluses or they have poor circulation in addition to that loss of protective sensation that you're diagnosing, that referral, it becomes necessary and it should be urgent referral. Whereas, and when they get to us, we're going to see them probably every 2 to 3 months for the rest of their life after that because of the high risk of developing foot ulcers. It can be a simple scratch that turns into a disaster. So we're trying to avoid that. And at this point, you've identified it, simply refer and get the podiatrist involved. A note on vascular studies. If you don't feel those pulses, it's recommended by the American Diabetes Association for anybody with diabetes over the age of 50 to have non-invasive vascular studies performed. Here is a list. I won't elaborate this. This will be shared with you for your reference, but certainly we're looking for people to be in this top layer to have normal ankle brachial blood pressures and toe pressures above 80. The reason we give you all these different forms is because people with diabetes can have calcific arteries and their pulse pressures in their feet may be abnormal. So this is just a good reference and something that we use to declare somebody as having normal or abnormal vascular studies. So if you have somebody who is then in that high risk category, whereas they're coming to you already with a history of an amputation or ulceration even, or some type of fracture due to their neuropathy, you want to get them into accommodative foot gear right away. They shouldn't be walking in just a regular shoe. Even if you see them and they're like, I had a foot ulcer, but it's never happened again. Your flag should be high up in the sky to say, nope, you need to be in protective shoe gear right away. Don't delay. And then consider multi-specialty involvement and call the podiatrist and get them seen right away to reduce that risk. So seems pretty simple, straightforward, but the key is identify what is going on and then get the specialist involved immediately based on their risk categorization. So I'll give you an example here. How often would you recommend this person to be seen by the podiatrist with this presentation? Among other things, some erythema, potentially asymmetry between the left and the right foot for sure. So how often do you think? Is this for me to fill in?
Nope, the poll is launched, so you can answer it if you'd like. And the responses are coming in. Once everybody answers, I will end the poll and share the results.
Okay. I'm just going to click annual just to keep everyone engaged. Lots of questions coming up, just to give you some examples of what I'm talking about. So.
Looks like we have a majority of responses. I will end the poll and share it, and then it'll show up for everyone on their screens, Dr. Schmidt, with what the poll answers are.
Okay. So then Okay, every 3 to 6 months, okay, is kind of a tie at the top there. And I think this is probably more urgent because this person looks like they have some type of peripheral vascular disease, putting them in that high risk category. So that is automatic, maybe loss of protective sensation. We don't know based on the picture, but it looks like there's some type of vascular component to it. Very cool. So thank you. So then we're going to talk about diabetic foot infections briefly. I'm going to go through this a little bit faster. We don't have to put the polls up for this, Jackie. I just want to show some examples of how a foot ulcer looks through the different stages so that everyone can appreciate the urgency associated with infection.
Okay, I won't launch one unless you specifically change your mind and ask me to.
Thank you. Thank you so much. And this is from the Infectious Diseases Society of America. They have a whole spectrum on diabetic foot infections. And this is again categorized in 0, 1, 2, 3. So first one, category 0 would be non-infected or uninfected. And this is just without the classic symptoms of infection. No rubor, no calor, no warmth. So absence of those sensations means not infected. Whereas if we go to stage what's listed as B, C, and D, you start to see that the erythema grows and expands from mild to moderate. And that's really the only thing that's telling us how severe the infection is, right? Infection is diagnosed clinically. So we're going to use your brain power to appropriately categorize these patients, and that tells us what to do. If we get too severe, this is when these patients are systematically ill or systemically ill, and they're, also having signs and symptoms of that via their vital signs. But if you have somebody who has a non-infected, there's not much to do. There's just wound care. Whereas if we go through and we go down to the mild to moderate, this didn't align, but mild to moderate is just going to be an oral antibiotic, something like Augmentin or Keflex would be just fine for a person with diabetes because it's going to likely target the best organisms that are causing or the pathogens that are causing the infection. Um, and this is opposed to where you have severe infection. If you have a cotton tip applicator, you can probe the wound and see if you feel a deeper structure. Sometimes you'll feel a hard stop, and that would likely be a bone, and that's going to elevate this from probably moderate or mild all the way up to this higher level severe category because that patient needs urgent attention. And we know probe to bone, it's not perfect, but it does work pretty well in the inpatient setting, particularly in the outpatient setting. Know that if you can just touch the bone, it doesn't mean it's osteomyelitis, but certainly if you're going deep into that wound, you want to have a higher level of suspicion of deeper concerns requiring more urgent referral. So again, those patients, without saying, they should be hospitalized if it's a very severe infection. So let's talk about the difference appearance. I'm going to go through these kind of fast. It's the same ulcer on the same person at different points of care. So first is a non-infected ulcer. We're going to see that it's just looks normal. It's kind of dry, no drainage, no redness, no systemic signs of infection. This would be opposed to somebody where a couple weeks later the person comes in, the ulcer's expanded, it's starting to look a little bit angry, whereas there's erythema and maybe some moisture along the edges of the wound. And that would be classified probably as a moderate because that erythema is going distally to the toes. Versus a mild infection, which would be something like this, where there's still a wound, there's less maceration, but that erythema looks like it cessates or stops right before that big toe joint. So it's not extending very long. And that's all it is for infection classification. A severe infection is something that looks like this, where there's purulence coming out of the toe. The toe looks dusky and purple. It's probably got a bad malodor to it, or not bad malodor, excuse my redundancy, but it has malodor associated with it. And that would, even though it's just a toe, requires very urgent care because that person is going to lose probably a portion of their foot as a result of that. So that would be moderate or severe, depending if there's associated systemic signs of infection. The last thing, the third thing that I want to emphasize today is the therapeutic shoes. And this relates back to the diabetic foot risk categories. This is CMS language. I'm sorry, it's not a great read. It's hard to present, but it's important to see how it is written on the local coverage determiners for this. So therapeutic shoes are offered to people each calendar year if they have diabetes. So note that it covers one pair of shoe and pair of extra depth insoles, and those are made to protect the skin from breaking down. So you get the one pair of shoes, one pair of insoles, right? But then also they cover two additional pairs of inserts. So three pairs of inserts each calendar year with that diabetic shoe. And this can happen in January. It can also happen in September. So it just depends when you see the patient, but they're eligible for that calendar year. And so if you get them coming to you in July in 2025 and then you see them in January, you can get them two pairs of shoes at that time. That is fully allowable. But what does it require? So a person must have diabetes, and then like the risk categorization classification that we discussed, it has to have only one of the following conditions, right? This is one or more. So you're already doing that exam. You can incorporate that and advocate for these patients to get their shoes. And this is covered by Medicare. So most private insurers also follow the same guideline. So again, previous amputation, previous foot ulcer, again, that's that severe risk category. And then we start talking about presence of peripheral neuropathy, which is kind of that stage 1 category, and even things like poor circulation or a foot deformity. I mean, almost everybody in my world has a foot deformity, but it's pretty easy to justify that. So think about that as you do your inspection, because that's going to help you advocate for your patient to receive these therapeutic shoes to prevent complications. There's more specific requirements in that they have to have somebody who I, as a podiatrist, cannot give therapeutic shoes without your help. So primary care, endocrinologists, diabetologists, they just need to have their diabetes managed. So if you're already doing that, you are the one that can facilitate them getting the shoes more rapidly because you've done the inspection. You are the one treating the diabetes, and you now know that they are entitled to get one pair of shoes per year based on CMS rules and guidelines. Other things is that, and this isn't pertinent to you, but the supplier has a couple things to do. So when you're working with an orthotist or prosthetist to give them the shoes, they have some modifications that they'll put in there and probably just require an additional signature from you to ensure billing compliance. Nothing to do on your end. This is again, what type of modifier is used to bill for the shoes. I don't know that you would do this, but I wanted to include it because it's all in that LCD, and I think it's nice to have it at your hand so you know what modifier might be applied so the patient doesn't get a hefty bill for diabetic shoes. So, as we talked about above, you got to document these findings. You're already doing it. Just say what we've reviewed, and the person will get these shoes. And then you have to indicate agreement that the person or the podiatrist with all the is within 6 months prior to delivery of the shoes and document that criteria. So this is very helpful. I think it's listed for you. This is just copied from the LCD for your reference. And it's also from the Therapeutic Shoes for Persons with Diabetes Particle Act from CMS. Other things, just make a quick mention because I know I have a few minutes here, or maybe a minute. But one thing you can think about in describing wounds, this is just a helpful way to do it. We call it measurement, and it gives you a nice acronym to think about what a wound looks like so that you can identify if it's infection and act accordingly. So these are what the letters stand for, and just some words that can help describe what's going on with that ulcer. Certainly, we are here to help, podiatrists or foot and ankle specialists can provide all these details for you. So if you do have concerns, especially if a foot ulcer is presenting to you out of the ordinary or in from the wild, I think you want to get specialist care right away. And now you should be tasked and have some of the tools to help you do that. That's all I have, because I think I was given 25 minutes. So certainly here to help you, and questions, I'm happy to take those. Thank you.
Thank you, Dr. Schmidt. Perfect timing. If anyone has any questions, if you could please put them in the chat, or if you prefer, feel free to unmute.
Hi, this is Noah from MCT2D. Hi, Dr. Schmidt. Thank you so much for providing the coverage criteria for the diabetic shoes. We've just heard from some practices that they've really struggled with it. In addition to the guidelines, do you have any tips for practices, or does anyone else on the call have you had that experience?
I will say personally, like the biggest issue that we have is not having coordinating documentation. So when the primary care works, obviously, like I work in an endocrinologist department division at the university, but even then, like the documentation does not communicate well. So if you can work closely with whoever you're referring to, your partner in crime, so to speak, here, the shared documentation would facilitate that getting less denials on the diabetic shoes.
Thank you.
Sure, thank you. Great question. Oh,
The other question in the chat was, what was the answer to the poll regarding how often to see the patient? The results are being reshared, but the correct answer was every 2 to 3 months, right, Dr. Schmidt?
yes, because of that that PAD or peripheral vascular disease component. Suspected.
I got it wrong. I said 1 to 2 months.
Well, 1 to 2 months is not necessarily wrong, but
Mhm. So the question in the chat is, when can a patient wait to see the podiatrist versus going to the ED? Mhm.
I think it's based on your level of comfort. If you're happy to prescribe them an antibiotic for a mild or moderate infection without systemic signs of concern, I think that's reasonable to wait. I certainly wouldn't wait with an infection more than a few days. But if you have close communication, I think it's reasonable, especially with like the laws of protective sensation or the PAD. Those things can wait as long as it's not infection, a manifestation of infection. I think it's reasonable to wait. Yeah, that's a great question. I mean, I think the ERs always would say, have primary care look at it and try to keep these patients out of the ED, but certainly develop those relationships so that you can facilitate quicker and better access for these folks that are having urgent issues.
Great. Thank you so much, Dr. Schmidt. We really appreciate you being here today and going over this with the collaborative.
My pleasure. Just gonna stop screen sharing and then I'm gonna darken my screen.
Okay, sounds good. Dr. Eng, while you're pulling up your slides, I'll go ahead and give an introduction for you. So Dr. Lin Eng is currently a clinical associate professor in the Metabolism, Endocrinology, and Diabetes Division at the University of Michigan. She is one of the principal attending physicians for the Diabetes Transition Program. Her clinical and research interests are in the fields of implementing optimal management of inpatient and outpatient hyperglycemia, creating protocols for inpatient hospital guidelines, identifying biomarkers to predict the development or progression of diabetic complications, among other things. She also serves as the co-chair of the Hospital Intensive Insulin Program and has been actively involved in teaching internal medicine and podiatry residents, endocrinology fellows, and medical students in both ambulatory and inpatient clinical settings. And with that, I will hand it over to you, Dr. Eng.
Thank you, Jackie, for the kind introduction.
Mhm.
Can you see my presenter view?
Yes, we can.
Thank you. Hello, good afternoon. Thank you for attending the Learning Community event again. Today I will be talking about the understanding and treating painful diabetes neuropathy, a common yet often challenging complications of diabetes. I do not have any disclosures. So for next 25 minutes or so, I will focus on exploring different types of diabetes peripheral neuropathy DPN to better understand the range of clinical presentations. Then I will go through simple, sensitive, and cost-effective approaches to diagnose DPN in clinical practice. Then finally, we will go over evidence-based strategies for both preventing and managing painful diabetic neuropathy. I would like to start off with the clinical case to ground our discussions in the real-world setting. After reviewing the data and evidence surrounding the diabetic neuropathy, we will revisit the case to apply what we have learned and discuss management strategies. So, 60-year-old man with a 12-year history of type 2 diabetes, hypertension, dyslipidemia, CAD, chronic back pain, presented with burning pain in both feet, worse at night. He was taking metformin, lisinopril, metoprolol, atorvastatin, aspirin, amitriptyline 75 milligram a day, and oxycodone 15 milligram Q6 as needed for back pain. On examination, blood pressure a little bit higher than we would like, BMI 35, and A1C 8.2. Here are the cholesterol tests. So let's start with the different types of DPN. This picture classifications is from the American Diabetes Association neuropathy statement that was published in 2017. The most prevalence found by far is the distal symmetric polyneuropathy. Patients may present with isolated small fiber neuropathy or isolated large fiber, or more commonly combinations of both. In addition to this, there's other types of neuropathy, such as mononeuropathy, radiculopathy, and autonomic neuropathy. Those are beyond the scope of our talk today. DPN is caused by progressive damage to initially small myelinated and unmyelinated fibers, which are responsible for nociception and protective sensations, then progressively damage to large myelinated nerve fibers, which control pressure, sensations, and are very important to maintain the balance. Of course, this occurs in symmetric distal to proximal fashion, referred to as the stalk and glove distribution pattern. Now let's go over the diagnostic approach. Start with the small myelinated nerve fiber evaluation. There's a server tools available to evaluate these nerve fibers. Please note that only up to 50% of patients are symptomatic. So the signs and symptoms that patients are having are driven by a specific nerve fiber distributions and damage. Small myelinated and unmyelinated fibers damage will present with pain, perceived as burning pain, stabbing pain, electric shocks. Again, these symptoms occur in distal to proximal symmetric factions, which are the hallmark of DPN. Examination includes temperature discrimination. Start with the dorsal aspect of the hallux and moving proximally until the sensory threshold is established. Push pain, you can use push pain for pinprick sensations or pain. If signs and symptoms are symmetrical, not symmetrical, this reduces the likelihood of this being diabetic peripheral neuropathy. Yeah. For large fiber neuropathy, patients usually present with numbness and tingling and poor balance. Examinations include the reductions or absence of vibration using a tuning forks, proprioception, ankle reflexes, and light touch sensation using 10-gram monofilament. So exam again should be done in distal to proximal factions. For DPN screening or light touch perception, the evaluations or dorsal aspects of great toes bilaterally is required. Please note that 10-gram monofilament is not used to diagnose or exclude DPN, as it detects only advanced stage of diabetic neuropathy and also at risk of full ulceration. It does not reliably identify these individuals with early stage of disease that would be most benefit from therapeutic intervention to prevent progressions of DPN. So additionally, these exams is quite different than 10-gram monofilament tests they use to assess the risk of full ulcerations at high risk. That's the provider should not use this test as a only method for DPN diagnosis, despite we noted its widespread use in the primary care setting. Nerve condition studies and quantitative sensory testing are being used in the research setting, but unless these are atypical signs and symptoms, these electrophysiology testing is not required. This slide shows simple tools that are available in the clinic care for the diagnosis of DPN. Tuning forks for vibration sensations can be also quite very used well for temperature discrimination. Reflex hammer to check ankle and knee reflexes, Tangram monofilament for light touch sensation, and push pin for pinprick sensations or pain. The American Diabetes Association recommends combining two of these tests to increase the chance of correctly identifying early stage of diabetes peripheral neuropathy. There's a few clinical instruments for screening. These three clinical instruments that have been tested and validated against large batteries of clinical science, electrophysiology, and quantitative sensory testing. The first is the Michigan Neuropathy Screening Instrument, MNSI Index, which includes combined questionnaires and clinical exam inspecting for ulcerations, vibration sensations, and ankle reflexes. Toronto Clinical Neuropathy Score and Neuropathy Disability Score are a little bit more complex, including additional exam on top of the one that we have in MNSI, and then these score giving you the degrees of severity or DPN as well. But these instruments are only primarily used in the research setting. It's not in the clinical care. We have talked about how to screen, but when do we screen? You have heard from Dr. Smith about this also before. For people with type 1 diabetes, the ADA recommends screening starting after 5 years of diagnosis. For type 2 diabetes, ADA recommends screening start at the diagnosis of type 2 diabetes. Patients should be screened annually unless they are high risk for food ulceration. Dr. Smith has talked about who are at high risk. This includes people with poor glucose control, peripheral arterial disease, already diagnosed with DPN, and food deformity, pre-ulcerated callus, and previous histories of food ulcers and amputations. Screening again should include 2 or more of these following tests: temperature, vibration, pinprick, light touch, or reflexes in a distal to proximal fashion bilaterally. Okay, why do we need to screen though? So diabetes peripheral neuropathy is very prevalent and has significant clinical implications. For people with type 1 diabetes, the Diabetes Control and Complication Trial, DCC, is the cohort that has most comprehensively phenotype for both peripheral neuropathy and autonomic neuropathy, with the entire batteries of symptom, neurology exam, and electrophysiology testing during both DCCT EDIT randomized control trial period and also during the EDIT observation and follow-up. As DCCT EDIT and also other cohorts have shown, up to 35% of people with type 1 diabetes may have neuropathy after average 25 years of diabetes duration. It can also up to 50% in people with type 2 diabetes are average after 10 years of diabetes. But the data for type 2 diabetes are a bit complex, as none of the large trial had such comprehensive evaluations of peripheral neuropathy like DCCT had done. I also would like to highlight the fact that children and adolescents can also have these complications, which is very concerning. DPN is found in diabetes with you in both type 1 and particularly more in type 2. It's about 7% in you with type 1 and about 22% in you with type 2 diabetes, average after 9 years of diabetes. So what about painful diabetes neuropathy? Up to 30% of patients may experience painful neuropathy symptoms, and this is a common trigger for patients to seek care. There is a female gender predominance and associated with age, durations of diabetes, and obesity. Painful neuropathy is also associated with nocturnal exacerbations leading to sleep disturbance, mood disorder, including anxiety and depressions, and poor quality of life. So peripheral neuropathy is highly prevalent, but why does this matter? As you learned from Dr. Smith, the annual incidence of food ulcer in people with diabetes is around 2% in most Western countries, but in certain populations, such as Medicare beneficiary and U.S. veteran, they experience significantly higher rates, approximately 6%. So as Dr. Smith eloquently emphasized, that diabetic foot ulcers are not only distressing for patients, but also associated with substantial healthcare costs. More importantly, diabetic peripheral neuropathy is leading contributor to foot ulcerations, and it's a key factor in the development of foot deformity, including Charcot neuroarthropathy. And even more concerning, once a person has an amputation due to a neuropathic ulcer, that person's prognosis changes dramatically, and mortality rates are similar to the most serious type of cancer. As you can see here, it's similar to colon cancer and Hodgkin disease. Additionally, there's a lot of data showing the impact on daily function as well. An interesting study here looking at the impact of neuropathy on driving, and found that participants with neuropathy had impaired control of accelerator pedal during the driving activity, leading to more loss of control events while driving. And then emerging evidence from several groups of investigators also demonstrating how neuropathy negatively affect balance and gait, leading to increased risk of fall, which can similarly negative impacts on mortality and quality of life as well. So in this study of people with painful neuropathy, they evaluated the pain severity associated with the daily function, sleep impairment, and symptoms related to anxiety and depression. They reported that the greater levels of DPN correspond with higher symptoms level of anxiety and depression, in addition to more sleep problems and physical functions and others. So we have talked about how to screen, how to diagnose the DPN. Now, how do we treat these people? So the pathogenesis of diabetic peripheral neuropathy is quite complex. Why, hyperglycemia plays a major role is not just one factor. As you can see in this busy slide, which is adapted from ADA, other contributors including chronic inflammation, dyslipidemia, insulin resistance, mitochondrial dysfunctions, and altered metabolic pathway, among others. Our understanding of this complex pathway has been significantly evolved over the years, but being said that, I just would like to focus on specifically on glucose control, because it still remains a key modifying factor in managing and potentially slowing down the progressions of DPN. So we learned a lot about strong evidence about glucose control for type 1 diabetes in preventing or progression complications from DCCT trial. Data has shown similar to both DPN and cardiovascular autonomic neuropathy, which is another type of neuropathy. About 60% preventions in complications in intensive therapy group compared to conventional treatment group. Although the lack of separations of hemoglobin A1C during the EDIT observation and follow-up study between these two groups, there continue to be observed a persistent benefit with much less neuropathy being developed in the formal intensive insulin-treated group compared as to conventional group as shown here. The phenomenon that was observed for all the rest of the diabetes complication, not just neuropathy, that phenomenon is called metabolic memory. So, however, people for type 2 diabetes, the effect of glucose control on DPN are less conclusive. It is likely because the presence of multiple comorbid conditions, risk factors, use of several glucose lowering agents to achieve targeted glucose control, and also use of different outcome measures to define DPN in this study. So all of those can make it harder to see a consistent effect of glucose control on DPN in this population. So aside from glucose control, there are some promising data for lifetime interventions. Here is one of the examples from University of Utah, who did a diet and exercise intervention model kind of similar to diabetic prevention program, and found improvements in re-innervations as measured by intraabdominal nerve fiber density from skin patch biopsy at 30 days and 90 days intervention, along with improvement in other metabolic parameters like weight and triglyceride. Similar cohorts are replicating this finding, so this is kind of promising area criteria for targeted therapy down the line. So there's also another randomized control trial, including 31 people with type 2, small number though, undergoing cycling training, 3 sections per week over, I think, 12 weeks periods. As you can see here, the cycling training can significantly improve lower limb vascular functions in patients with diabetes neuropathy and glucose control, and also improvement sensing neuropathic symptoms as well. Now moving on to management, the FDA-approved oral agents for painful diabetes neuropathy includes pregabalin and duloxetine, both of which have similar efficacy and number needed to treat about 3 to 11 range for achieving 30 to 50% symptom reliefs. Commonly used off-label options include carbapenem and triglycyclic antidepressant such as amitriptyline, which can show a good benefit with number needed to treat between 3 to 7 range. These agents tend to be less expensive, which may be a key consideration if the cost is a concern. In order to see a meaningful symptom relief, higher doses are often required. How about in patients with reduced kidney function? It is important to adjust the dose based on kidney function, particularly for medication like pregabalin and gabapentin that are renally excreted. All of these medications have potential side effects, which kind of open the door for shared decision-making between providers and patients, balancing benefit, side effect, cost, and comorbid conditions. Additionally, evidence from 2 large 12 weeks randomized multi-center trials leading to FDA approval for a tropical capsaicin 8% patch. This high concentration patch works by blocking the pain receptor. The studies demonstrate about 30% pain reduction, but it is important to note that the patch must be applied in the office by the trained personnel for approximately about 30 minutes, no more than 3 minutes interval. The most common side effect is like irritation and burning at the sites of applications. This was a multi-center randomized double-blind crossover trial involving participants with painful diabetes neuropathy and a mean daily pain scores above 4 on a numeric rating scale between 0 to 10. The study recruited participants from 13 UK centers and randomized them to receive one of the 6 treatments sequence of 3 treatment pathway. Amitriptyline supplemented by pregabalin supplemented by amitriptyline, and duloxetine supplemented with pregabalin. So each treatment pathway lasted 16 weeks, starting with 6 weeks of monotherapy, followed by combination therapy if pain remains suboptimal. All medications were titrated to maximally tolerated dose, 75 milligram for amitriptyline and 120 for duloxetine and 600 for, I think, pregabalin. So the primary outcome was to see the difference in 7-day average daily pain during the final week of each treatment period, as shown here. All treatments pathway, any sequence resulted in comparable and significant pain reduction with the average decrease of 3.3 points on the numerical rating scales, which is approximately about 50% reduction from the baseline. So these findings suggest a flexible patient-centered approach to therapy, allowing clinicians to tailor treatments based on individual tolerability and comorbidity and also access to medications. How about opioids for painful DPN? About 30% of patients receive an opiate as a first-line agent for diabetes neuropathy, and about 20% go on to use opiate therapies as a long-term treatment, with about 50% of these due to neuropathy-specific indications. So opiates are associated with poor functional status, very increased risk for dependency and opiate overdoses. So there's one FDA-approved opiate tapentadol for treatment of painful neuropathy, but that agent was only approved of 1 study alone. And then the risk for abuse has been reported so many, including this report with the cardiac arrest. So here is the American Diabetes Association position statement algorithm for the treatment of painful diabetes neuropathy. Once you have confirmed that the pain is due to diabetic peripheral neuropathy, the next step is to check the patient's comorbidities, consider potential side effect of various medication before selecting an appropriate first-line agent. I usually start with one of the FDA-approved medication, either pregabalin or duloxetine, if insurance coverage permits. If pregabalin is not covered, then gabapentin is a reasonable alternative with clinical result. Another option is tricyclic antidepressant, such as amitriptyline. While it is not formally FDA approved for this specific indication, but it is often used as a first-line agent. However, it's very important to monitor anticholinergic side effects, especially in older adults, and also to be cautious to be used in patients with cardiac disease due to some study reporting increased risk of myocardial ischemia and cardiac arrhythmia associated with all tricyclic agents, though. The key is to titrate the medications to the most effective dose that the patient can tolerate. And if there is a little to no improvements in monotherapy, then you could consider either switching to a different agent or adding a second medication to the first one. If the patient continues to have significant pain, despite combination therapy or patient cannot tolerate the medications, then consider referring to neurologists or pain clinic may be appropriate. But finally, it is very important to highlight that the guidelines, any guidelines, American Diabetes Association guideline or American Neurology Association guideline, all the guidelines strongly recommend against the use of opiates for treating painful diabetes neuropathy. So going back to the case, this man clearly has metabolic syndrome, overweight with central obesity, hypertension, dyslipidemia, low HDL, and suboptimal glucose control, and high triglyceride. And unfortunately, he already had a cardiac disease. So certainly he's a high-risk patient from both cardiovascular standpoint and also as was a neuropathy standpoint. So the question is, what should be the next diagnosis step? I asked Jackie not to add the pool because there's a more than one correct answer. So you could consider refer to neurology EMG testing. A, B is just to focus neurology exam in the office using bedside tools, at least 2 tests. And then C is assessed to do just light test sensation with a monofilament test or check the labs. So the answer are B and D. During the exam, I found that he had a bilateral diminished sensations to vibration. So that suggests of large fiber neuropathy. He also had a reduced sensation to pinprick. So just that also suggests it's a small fiber neuropathy. So he therefore has a mixed small and large fiber neuropathy, which is again most common presentations of diabetes neuropathy. Another correct answer is D, to check DPN mimic condition, because diabetes peripheral neuropathy is a diagnosis of exclusions. Even one clinical presentation strongly suggests diabetes peripheral neuropathy, it is important to keep a broad differential diagnosis because people with diabetes can have coexistent causes of neuropathy, some of which may be easily reversible with appropriate treatment. So ruling out these causes such as vitamin deficiency, alcohol-related neuropathy, thyroid dysfunctions, medication-induced, some infection is essential to avoid overlooking treatable conditions and also to ensure optimal care. So next question is, how will you manage pain in these patients? A, start amitriptyline 50 milligram at night. B, prescribe pregabalin 75 twice a day and titrate to 300, or recommend tapentadol or stop oxycodone. So this patient has been taking amitriptyline, which is used off-label for treatment of neuropathy, so which is totally fine, but doesn't seem to be walking with his symptoms, and with underlying, cardiovascular disease, may need to consider something else. So more concerning is use of oxycodone, which is an opioid, and he has been using it for for back pain and neuropathy, but clearly wasn't affected. So at that point, we discussed the treatment options, and we switched amitriptyline to pregabalin because patients' insurance cover, which is also FDA approved. So he had better response, and also his suboptimal glucose control and underlying coronary artery disease. So and obesity, we added GLP-1 analog to his regimen. So take-home messages: diabetic peripheral neuropathy is common complications of both type 1 and type 2 diabetes. It carries significant clinical consequences such as severe pain, impaired daily functions, reduced quality of life, depression, anxiety, increased risk of mortality, and lower extremity amputation risk. Diagnosis is pretty straightforward. It's based on clinical history and targeted physical exam using simple bedside tools. So sophisticated testing or neurology referral are rarely necessary unless presentation is very atypical. So pain management should be evidence-based and avoid narcotics. With that, I will end my talk, and I welcome the questions. Thank you so much for your attention.
Thank you, Dr. Ng. Same as before, if anyone has any questions, if you can either put them in the chat or unmute and ask them, that would be great.
You have 4 minutes.
There was a question in the chat. Dr. Ng, can you comment on Mentanks?
I don't even know what is that. I'm sorry. It's a supplement.
Yeah, Dr. Bradley, can you expand a bit?
Sorry,
Yeah,
Dr.
can
Bradley.
you hear me?
Yeah,
Yep.
we can hear you.
Okay. Yeah, it's called Metanex, METANX. And it's a supplement that's over the counter that they're selling for distal symmetrical painful neuropathy. Have you heard of it? Have you used it? Can you comment on it?
Oh, thank you. There's a lot of study looking at supplements, including thiamine, B12, vitamin D, alpha lipoic acid, and acetylcarnitine. But currently, there's some. I don't know about this, so I'm not sure about there's a clinical trial for that particular supplement. I have no idea. But among all those supplements that study, one of the promising data is for alpha lipoic acid. There's in terms of patient population design of the study. So some of the clinical trial data mostly from European country kind of shows improvements in neuropathy symptoms using alpha lipoic acid, but some of the data are not showing that. So it's kind of still mixed. So I have never used that supplement that you mentioned, but I have done, if I'm thinking about like I have tried everything. You might have some patient like that. I have tried everything. Patients still having pain, and then and also having a lot of side effect because of increasing dose of patients medication for painful neuropathy. Then I might ask them to okay, there's no harm in taking supplemental medication like alpha lipoic acid. I might suggest them to use 600 milligrams once a day, add into whatever they are taking, or and see. So I have some patients, they tell me that they are kind of feeling a little bit better, but some of them are not, did not see the benefit. So if I'm thinking about supplement, I usually try to suggest alpha lipoic acid. And then definitely when I looked at when I check for lab for, secondary causes of diabetic neuropathy, I would always check B12, thiamine. So whatever vitamin D always is in there. So whatever I might supplement, as needed, depending on the level.
Okay. One other comment, real quick. Can you comment on CoQ10? People like to take that for neuropathy as well because of the antioxidant effect of this.
Yeah. So I know people take a lot of supplement, but I did not come across a lot of study about CoQ10 for diabetic neuropathy per se.
Okay.
There were a couple other questions in the chat. Someone said that they found success with the capsaicin 8%, but it's rarely covered by insurance. Is the over-the-counter dose effective? And then insurance also wanted them to fail on lidocaine, and is that effective? Mhm.
Lidocaine is not formally approved, but people kind of use it. I have not used it in the past at all. Regarding over the capsaicin, I think some people try it, but it's that kind of low concentration, so it's associated with less side effect. You know, usually 8% kind of people mention about burning and irritation at the site of applications. And yeah, I think insurance is a little bit issue. To be honest, in University of Michigan, we don't have that resource at this moment. So
Last one, and I know we're at time, so I understand if people need to drop. But can you comment on the use of SGLT2 inhibitors and the risk of neuropathy from those, and who should we avoid them?
oh, are you talking about the questions kind of aim for orthostatic hypotensions can happen with autonomic neuropathy in people with diabetes, and SGLT2 inhibitors kind of reduce the blood pressure. That's the questions, or are you asking about some beneficial effect on nerve with SGLT2 inhibitors?
Well, is there a risk of, oh, sorry, go ahead.
Oh,
Okay.
sorry. There were early studies that maybe SGLT2 inhibitors increase the risk of diabetic foot wounds and
Oh,
whatnot.
I see.
And so it's been, I think studies have been mixed. And so it's hard to know who we should, we're trying to get good glucose control. Should we use them? Should we not use them?
Oh, yes, very good question. In the past, FDA had a black box warning saying that, be careful about saying that risk of amputation with peripheral arterial disease, and for SGLT user in people with type 2 diabetes, but that black box warning has been removed for a while now. And then what I usually do, if patient had an active infection, full one, I might tell them to hold it until it's healed. But even some patients, even so there's always the discussion between your patients and providers. Always, I have one patient, he said he's pretty doing great on SGLT2. He developed a little bit of wound in his feet, but he didn't want to stop at all. So he continued and nothing happened. It's healed well. So but they should know, so they should always, there should always be a discussion between provider and patients about those risks. So what I usually do, I usually hold patient had an active wound in their feet, and then I will restart right away once it's resolved.
Thank you.
Thank you so much, Dr. Ng and Dr. Schmidt as well. And thank you all for joining today. We really appreciate it.